Hello, welcome to this podcast brought to you by Soft, hosted by me, Nick Holladay. And in this particular episode, Dr. Carey will be my co-host, and we have the privilege of interviewing Dr. Alaina Pyle. Dr. Pyle is a neonatologist and works a lot in bioethics at the Connecticut Children's Hospital. This particular podcast, we will be discussing the latest monumental report from the American Academy of Pediatrics. This particular report helps revolutionize and change the outdated concept that children with trisomy 18 and trisomy 13 were incompatible with life. Now, Dr. Pyle is the author of this report, and so we'll have the privilege of hearing from her what caused this report to be created, what she hopes this report will create for families, for medical professionals, and for institutions that may see these children. And so being able to have Dr. Carey tell us the insights of the past for these conditions and hearing Dr. Pyle relay what she hopes to see that this report can change, I was just privileged to be able to join them, and I think you'll really enjoy it. Now, if you do enjoy it, please comment, please share. And again, thank you for listening, for watching, and doing your part to help support families with trisomy 18, 13, other related disorders, as we all work together to help change the narrative for these conditions. John, thank you, Dr. Pyle. We're excited, and I'll let you guys introduce yourself. You'll do yourself justice rather than me reading a script. So John, say hello and tell everybody about yourself.
Good morning. John Carey, faculty member at University of Utah, Salt Lake City, Utah. I've been on faculty since 1979. I'm actually officially retired, but as many who are listening to the podcast know, I'm working but retired. So I'm now officially a emeritus professor on our faculty in the Department of Pediatrics. I've had a very long and deep interest in chromosome conditions in general as a medical geneticist and pediatrician, but I've had an actual special interest in trisomy 13 and 18 since I had the honor with two mothers, including Nick Holladay, now in Arizona, mother then of Carey, of helping to form the support organization for trisomy 18, 13 and related disorders. And I've had the privilege in my professional career to attend every conference that has occurred, first one being in Salt Lake City in 1987. And I've gone to all of them and to have had the experience of meeting many families and many of their children and adults with the two conditions. So I think I'll stop there and we'll go on.
Yes, John, thank you for all that, and a lot of great lectures and support of families that you provided over the years. Dr. Pyle, again, thanks for joining with us. Tell us what you've been up to recently. You're over there in Hartford, Connecticut. Tell us just give us all the details real quick, what you're up to.
Sure. And thank you for having me. I've also really been looking forward to this conversation. And back when I was first starting my interest in my career in this area, I still remember reading Dr. Carey's papers and, just such a phenomenal writer and so in touch with the families with these types of conditions. So I, as you said, I'm currently in Connecticut. I work at Connecticut Children's on faculty here in neonatology. I also work with our ethics committee quite closely and our fetal care center here in Hartford. Before that, I did my fellowship training at Yale, also in Connecticut, and that's where I got to work with Mark Mercurio, who is my faculty mentor. And we worked together throughout my fellowship on several papers, particularly on trisomy 13 and 18. And I can kind of at some point talk through that process and kind of how I got involved in this. Before that, I trained in Dallas, actually, at Children's in Dallas. I did med school and residency, pediatric residency out there. So I've been in Connecticut for a good 10 years, and it's a gorgeous fall day here. This is partly why I moved here. The weather here is just absolutely gorgeous, and I'm looking forward to the conversation today.
Just kind of give us a little bit about what's led you here, and Dr. Carey, let's talk about a little bit about the history of trisomy 18 and 13. But I'd just love to hear you guys kind of converse a little bit back and forth as kind of the two leading experts of these conditions right now. I know there's others out there, so I don't want to offend anyone, but just as what's going on with the world of trisomy 18 and trisomy 13 right now.
Sure. I can sort of start out, and um, I have been interested in ethical challenges in medicine as far back as I can remember, very early in medical school. That's part of what drew me into neonatology is, we are sort of at the forefront in medicine. I'm a little biased, obviously, as a neonatologist, but I think some of the more interesting, kind of really big advances are in our field over the last 20 years. It's just remarkable what we can do nowadays as compared to even 10 years ago, 20 years ago, 30 years ago. There have been tremendous medical surgical advances. And um, during my fellowship, I was already interested in sort of the challenges of end of life decision making, complex medical care. Um, Extreme prematurity is sort of the bigger picture that we see much more often in neonatology, and the challenges of trying to help families make decisions in that space. Um, it's very, very challenging. And as a new fellow, as a resident, I would watch my attendings who were very good have incredibly different ways of going about that counseling process, and sort of different ways that the parents responded to that counseling. And I was very interested in that space and how we help families make these incredibly hard decisions. And I think that sort of naturally led me into the trisomy 13-18 space. In conversations with Mark at the time, I think it was even my first year of fellowship, um, I found out that we had a policy, and this is actually in that paper, as you can see, where we did not offer interventions for parents of children with trisomy 13 and 18. That included nasal cannula, IV fluids. It just was not an option because based on the older data, these children were thought to not be able to survive long term. And I don't know, Dr. Carey, you want to take that space to talk just a little bit about kind of what historically was thought about trisomy 13-18 and kind of how that knowledge has evolved as the literature has evolved. A lot of work that you've done.
Right. Thanks, Dr. Pyle, for actually that particular question, because I think there is a unique way that trisomy 13 and 18 are viewed by our practitioners, both in obstetrics, fetal medicine, neonatology, and of course in pediatrics. And that view sort of arose gradually during the 1970s as newborn medicine, as you already pointed out, became getting to the point where they're advanced as they were. I treasure my memories in the early 70s when I was an intern and resident at University of California in San Francisco when continuous positive airway pressure was invented there. And the paper came out when I was an intern. And of course, a few months later, I was determined I was going to be a neonatologist. Another story why I'm not, but either way. So during that time, there was a paper that appeared in the 1970s that made the case that there were some children, trisomy 18, 13, and spina bifida were listed, where maybe it was better not to intervene and whatever we want to say, let things take their course. In addition, the syndrome book that everyone used and still uses, Dave Smith's Recognizable Patterns of Human Malformation, in that book, Dr. Smith actually said in the first 4 editions that when the diagnosis of trisomy 18 and trisomy 13 is made, the author recommends no interventions to prolong life. And I think that probably at least marked what was going on, not necessarily because he led the way, but it actually kind of was a biopsy, if you will, or a litmus test as to where we were. Other papers appeared in the 90s where you actually have recommendations because of the, quotes, hopeless outlook. Paper in one of the British medical journals in the early 90s. Because of the hopeless outlook, we shouldn't intervene or have surgery. They actually made that recommendation. The authors were from Holland, published in Britain. In the same year, another paper in the same decade, another paper appeared, which actually said, well, the children with trisomy 18 and 13 all die because their brain can't tell them to breathe. Central apnea, they all die. So therefore, there is no reason to consider doing their cardiac surgery. So I think those publications, that classic, outstanding book, one I've used all my life, and those two papers kind of marked what was going on in the field as we went into the 2000s. And in the 2000s, there started to appear papers that showed that intervention increased survival, and that surprisingly, to everyone's amazement, cardiac surgery in those who had it, which was quite uncommon in the 2000s, was quite successful. That is, over 90% of children left the hospital. So those particular events started, I think, on the road where we're still going, but where we've come to that because intervention made a difference, it's important to at least rethink this.
Mm-hmm. Yeah, that's wonderful. I mean, a couple of key things that I kind of picked up there, Dr. Pyle, was just like in your residencies, kind of hearing the different doctors that you had, you said just did a wonderful job, and each of them had a different style, and they could converse and talk through, circumstances and maybe some opportunities for some decisions. Dr. Carey, what I'm kind of gathering is that, over the years, there's been some opportunities for some this might not be the right word, but some investigating certain procedures. And there's been kind of just a layered approach to that, a very pragmatic over the years, and finding success where certain surgeries, cardiac surgeries or what have you, just kind of a remarkable time. When I've had a chance to interview and talk to families, rub shoulders with them, I know that, just like all things, technology, information has been just speeding up. Just look at the technology. Look, we're talking across the country very quickly, and it's been neat to see that these opportunities for families can have a variety of opportunities to think through some different opportunities for medical care. What a wonderful thing. John, as you see that evolution, let's talk a little bit about just trisomy 18 and 13, just maybe some of the statistical background, the occurrences, tell me a little bit, like, let's set the stage so we know. I think most people that are following this podcast or listening to us probably know these figures, but let's just make sure we have the ground level of the trisomy 18 and 13 kids. What are the diagnoses look like, how frequently, et cetera? Tell us a little bit about that.
Right. Thanks, Nick. So trisomy 13 and trisomy 18 are both human chromosomal conditions. They're the second and third most common non-sex chromosome trisomy condition, after, of course, trisomy 21 Down syndrome. They both involve having an full extra chromosome. In the case of trisomy 13, 3 13s. Case of 18, 3 18s. And this extra chromosome in both situations, as well as in Down syndrome, causes changes during development that leads to the physical syndrome that we see before birth and after birth in both trisomy 13 and trisomy 18. Trisomy 13 was originally described by Dr. Klaus Patau, University of Wisconsin. Dr. Smith, who I alluded to a minute ago, author of the textbook, was the second author. In the same issue of the British Journal of Lancet, the first paper on trisomy 18 appeared, again showing an extra chromosome, and that was described by John Edwards and colleagues, and has come to be known also as Edwards syndrome. On a note of history, we had the privilege of hosting Dr. Edwards in the 1990 SOFT conference in St. Louis. I had gotten to know him a little bit and got to know him even more at that meeting when he actually released a balloon. We don't release balloons anymore, but he released a balloon honoring the first patient with trisomy 18. So back on track, both of these conditions, both of these syndromes are medically serious. They're what we now refer to as being medically complex, primarily because of the pattern of birth defects that are different but overlap in both of the conditions. And also because of these birth defects, primarily those of the heart and those of the brain, children have the possibility of limiting life. And so survival figures in the first weeks, days, months of life are much lower than other children. And in addition, children with trisomy 13 and 18 go on as they live to have notable developmental disabilities. So in that way, the conditions have these three characteristics: the increased occurrence of birth defects, the concern about survival, excuse me, and the neurodevelopmental disabilities. So I hope that was a brief summary. I suspect many in the audience are familiar, but we wanted to emphasize the significance and seriousness of the condition, but don't want to forget also the many positive aspects that I've learned about by being with families who have that chance to rear and raise their child with one of these challenges.
Yeah. Dr. Pyle, do you want to add anything from Dr. Carey, kind of just the history and let's jump into like what caused you to just fall in. You go from being a resident, we're talking about, Dallas and Yale, and you're at these different places, and now we're seeing your name on reports and things. We've got the Journal of Perinatology, like I mentioned before. Start telling us kind of what led into that. So thanks for the history, John, and understanding the complexity and the concerns that exist around these two conditions. Dr. Pyle, you want to add anything, and then just jump in and kind of tell us what got you to start being a doctor with name on journal reports. But tell us a little bit what got you there.
Sure. Yeah, that was a fantastic summary, John. Thank you. And the only thing I add is that, when you have these birth defects and organ differences, that's sort of what often leads into the challenging decision-making process for both the medical team and parents who are in these really difficult situations where oftentimes there is no perfect answer. There's just, different paths that parents should have available to them. And I think that does sort of lead into why I became interested in this. I am a person who believes very strongly that people deserve information. 100 years ago in medicine, it was very different how we did things. You just sort of, as a physician, you just sort of did what you thought was right for the patient. There wasn't a conversation. There was not informed consent. All of these differences that are quite dramatically different nowadays, and appropriately so in my mind. And I felt that there were certain situations where families were not being told information that they would potentially find helpful. And I think that was for various reasons. And one of them includes the concern that as soon as you start offering things to people, particularly parents who desperately want to do the right thing for their children in almost every single case, are we passing on the responsibility of decision making? Are we abdicating our duty, giving up our responsibility as a physician, as a medical provider, and putting that on parents by giving them too much information, too many options that we don't think is right, based on, in my opinion, old data that really is not supported any longer, that, there is futility in providing surgical interventions, breathing tubes, new IV nutrition, all these different things that, we can kind of talk about the nuances of that if you'd like. But for a very long time, it was just, we were all taught. And I still remember in medical school and being told that these are lethal conditions. And then I came into fellowship, and lo and behold, that's not actually true. And that transition is very hard. And I think that's for a lot of different reasons as well. It's, potentially people, Dr. Carey watched this progression happen over his career, and you're able to change how you manage these patients. Take another physician who potentially has been, practicing medicine for 20 years, since the 1970s, when they told families, this is a lethal condition. We are so sorry. There's nothing we can do, and not offering any choices. And now here they are, 20, 30 years later, being told that's not actually right, that if we intervene, some of these patients are able to survive, as you said, Dr. Carey, like a significant portion, despite what we do and our best efforts and our best interventions, are not able to survive. But there is a portion of these children who have that potential. And so we have these providers who have to come to the recognition in their own mind that while they were doing their best, they're good physicians, caring, thoughtful, up to date on the literature, they let babies die who maybe didn't need to. And that's really hard. I think that's part of why this transition has been challenging, among other reasons. Just the sort of cognitive dissonance of that understanding that what you used to do was potentially wrong. And that's hard for people. It's sort of a long side tangent, but that is kind of what brought me into this, is seeing something that was done a certain way, and people are still hesitant to share information, both from it, do we even know this is really right? And also, are we burdening these families with choices that are so hard? And like, isn't it better to just not give them that information and not, give them this impossible choice, when most of the time these children are not going to survive anyway? And that's really hard.
It's interesting that you bring up some of those. And John, I'd love to hear your thoughts, but I had a chance, I get a chance to talk a lot with Chris Holladay, the founder of Soft, and I was picking at like, how did Soft come to be? And this story, if I can interject maybe just a perspective. So my sister, Carey Holladay, who John Carey talked about earlier in the podcast, she was born in 1977, and they were in the Bay Area. There will be another podcast with a really detailed story about Carey but I think this happens a lot where at the time there wasn't a lot of prenatal care. So just simply looking at it, Dr. Pyle, like you said, just the evolution of medicine, the evolution of resources, there was no ability to have prenatal diagnoses as much. And John, maybe you can correct me a little bit on that at the time. But so Carey's born at time of birth. There's just some signs. This is the second child in my family for Chris and Hal, and just things are a little different. And so quickly within the first hour of her birth, there was information provided to her like, things, we got to do some more testing. So they busily doing those things. And what came about, and I think this is to your point, where even under some circumstances, children are going to pass away within minutes or hours. And that's what this doctor and these medical professionals at the time were just saying, that this is a possibility. So enjoy every moment. And that kind of set the stage that's always kind of been around Soft, is enjoy every moment. But what happened with Carey was, despite just kind of this unknown, she survived hours, and then that turned into the weekend. And then it was like, well, what can we do now? And it was like, well, we could feed you through, a tube through your nose. And so just that in the scheme of things, I think that happened like at times for these families. And then it was like, well, are there others out there? And so as we look at Soft just as an organization to support families, John, over the years, it's just, we had a phrase at one point, respecting everyone, respecting you on your trisomy journey. And that's, I think, what we're looking for. And so the fact that you mentioned just provide as much information that we have today, up-to-date information, that's kind of our mission, releasing these new and expectant parent books, similar kind of goal of yours, is just like allow for a full range of information to be there. What touching kind of, you saw that, you're that type of person that just wants to be able to investigate a little bit more what other options we have. So there you go. So thank you, Dr. Pyle, for kind of giving us that background of yours. I know it just kind of hit home with the hope that we have at Soft, which is information, parent decision making, and then respecting all, every person, every family's journey. They're all going to be a little unique. But how can we make it the best decision at that moment? So thank you. John, did you want to, what comes to mind for you having seen this? You were boots on the ground through this kind of evolution time that we're kind of talking about. Do you want to give us some clarity around what kind of happened?
Well, as I mentioned, I went to every SOF conference from 87 on. Prior to that, of course, Chris organized parent meetings within Utah, and I met other families in this part of the region. And during that time, I've mentioned this to Chris, I sometimes struggled with, by everything that was happening, especially the conferences, was I facilitating false hope for people? And even at medical meetings, I would be challenged on, why did we even come out with that book? You're giving families the wrong impression. And we're talking now in the early and mid 80s. And I struggled myself. I never stopped thinking. But what really, whatever you want to call it, altered my view, whatever epiphany I had, came from seeing families and their children at these conferences. It changed my view. It changed the view of my wife, who was a NICU nurse in her original training and would come to the meetings with me. So I had this expression at the time, it's all about the kids. Now, that's not to say, as Dr. Pyle already alluded to, you did as well, Nick, that there are still many children, even now as survival has improved, who won't survive the first few days or weeks of life. In fact, statistics on the early survival haven't changed very much, even though figures on later survival and 1-year survival have changed significantly in the last 10 years over what we knew prior to 2016. So anyway, it was actually being at the conferences that had an influence on me. And there was a point that I reached somewhere, and I'm not sure, it was more than 10 years ago, before the figures on better survival started to come out, where I actually felt I needed to be a stronger advocate, at least for the family's voice. Not, let's say, for every baby needs to have cardiac surgery, but at least for their voice. Mm-hmm. And I don't want to give the impression that was that I'm boasting about that. It was something that naturally came, that I hadn't quite realized before, that was a threshold in my own life. So anyway, that I just wanted to add as I close this little section, that what we kind of alluded to but didn't mention is, starting in the late 2000s, studies from Japan were showing that cardiac surgery for relatively small groups of children improved survival. And then in 2016, 2 papers appeared the same year, one a multi-state study from the U.S., another from the province of Ontario, showing that 1 month, 6 month, and 1-year survival increased over the previous studies that we knew about and alluded to earlier. And because there were also parallel studies that showed more kids were having surgery, more kids were in the hospital, many kids were getting G-tubes placed, the conclusion was that this increased intervention was the reason for the increased survival. And then other papers appeared less than 5 years ago from Japan and the U.S., actually showing that in intensive intervention, including cardiac surgery, increased survival by varying degrees. In the case of Japan, over 50% of children survived the first year of life. So anyway, I wanted to make sure we mention that, because, correct me if I'm wrong, Dr. Pyle, I want you to jump in here after this. It was because of these studies over what now would be the last 9 years, that must have had something to do with setting the groundwork that you and the Committee on Bioethics and the other sections of the American Academy, because I don't know the answer to this, decided it was important for the most important and prestigious group in the world on pediatrics. The American Academy of Pediatrics leads the way. would convene a group of experts and thinkers to look at this in more depth.
Mm-hmm. Yeah, you're absolutely right. And, Mark always taught me good ethics begins with good data. It's one of my favorite quotes because I think without having information to make our ethical arguments more sound, we're just saying opinions at the end of it. So having those papers come out, and I will make the comment, I agree that was incredibly important. Some of the papers that came out of Japan that you mentioned, the survival for those patients tended to be with pretty significant medical and surgical interventions, some prolonged hospital stays, which did, play into some of the ongoing concerns for people who are reading these studies. It was a very long process, though, getting to the paper. I was actually looking back through all my old emails and documents and drafts of how we got there. And it was actually in 2018. I was working with Stephanie Kukora, who's in St. Louis. She was trained by Naomi Leventhal, who's the chair of the Committee on Bioethics. And we had met at a conference. Actually, we had both given talks about trisomy 13 and 18 and went to each other's talks and got to talking. And we actually still work together. And so back in 2018, as I was finishing my fellowship, Dr. Kukora sort of led the way for writing out a proposal for the AAP Leadership Forum. So every year, these proposals are submitted for sort of priorities, potential papers that would make sense for the AAP to support writing. And we talked about trisomy 13 and 18 and how the literature is evolving and really showing that it's not what we thought it was. And the AAP needed to address this because clinicians are struggling across the country, around the world, not knowing the right way to manage these patients, how to manage these conversations, not sure about what the best data is to lead sort of their counseling for these families. And so in 2018, we submitted that. It ended up getting accepted. And then it was a year later, we submitted an intent for the paper itself. So Dr. Leventhal led the way on that intent. She was, again, at that time, chair of the Committee on Bioethics, and she reached out to me and the other two authors on this report. I'm horrible with names, and I'm having a stress moment. I can't think of the authors' names right now. Jim Cummings. Sorry, you can cut this out, right?
Yeah, you just keep going. Just tell the story. You're good. But
Okay.
yeah, I felt for you. I didn't want you to
Okay.
feel like you let somebody out, let somebody down by not saying their name. So if they come to mind, you let us know.
Oh my God. I'm going back. I had the paper pulled up because
It's
have,
James Cummings and
thank you.
Naomi Leventhal.
And Tom George. There we go. Oh my gosh. I talked to them like literally dozens and dozens of times while we were writing this paper. I'm just bad with names. So, okay. So, Naomi Leventhal reached out to myself and Jim Cummings and Tom George. They each had an important role in the other relevant committees and sections with the AAP. We wanted to make sure to draw in the teams that we would need on board to publish a clinical report like this, because we knew even from the beginning that it was going to be somewhat controversial to really put, in writing that the AAP was saying that you have to offer at least, in discussions, interventions for patients with trisomy 13 and 18, and that it was no longer ethically appropriate to simply not describe what the medically appropriate, surgically appropriate medical interventions might be for that particular child. So we worked for another year and a half writing the paper. And because of the way the AAP works, which is wonderful, they really want to ensure that everyone that might have valuable input gets a chance to review these papers. So there were multiple committees and sections that reviewed it and offered feedback, and we incorporated the feedback and kind of sent it back out. And so that process itself took another 2 years altogether. Everyone's very busy. And so kind of the reading the paper and back and forth was a long process. And then we were able to get it out there into the world. It was very ironic to me that it actually came out the same time as the New York Times article for patients with trisomy 13 and 18. It's a beautiful read that was done with a lot of work over, I think, several years. I think, John, you were involved in that as well. And I actually sent that out to all of my colleagues because I thought it was just such a nice, very balanced, but very real kind of personal level look at these conditions in the very modern time period.
Yes,
Yeah.
speaking of that article, Dr. Sherry Fink did start attending a number of soft meetings about 10 years ago. I think it was 2012, 2013, even longer. Then attended the 2019 meeting in Michigan where she gathered more information. Then COVID came,
Mm.
and she was also working on a book on COVID. She's still working on, and then really wanted to come back to that particular project, which led to the paper, which literally came out about 2 weeks publication-wise, print publication-wise, after your paper came out.
Mhm. Mhm.
Yeah. I mean, to me, if I can like put just, I'm always fascinated by the length of time and just the evolution of it. I think of, as you're talking about peer review, like, are you kind of like politely texting or emailing, hey, do you mind just, can you go review that before the weekend so we can get to the next person? And so the fact that there's been just so many, I mean, John and I were talking off before doing this and chatting with you, just the length of time that it took. So it sounds like, I mean, there's a number of years from being accepted by the AAP to do this. Did I do my math right? When was that first kind of, yeah, you like, let's go ahead and do this? How many years was that? What year was that? Let's put it in math equation real quick.
Yeah, I think it was mid 2019 that we got official approval to move forward.
So yeah, and then even with times the year and a half or so of COVID that we had to
Yeah.
probably delay some things, but anyway, we're talking 6 years, 5.5 years, 6 years if we want to get really nitty gritty. So a lot of thinking this through, talking to a lot of wonderful people. There are a number of folks on the report. Again, if you go to the AAP report, we'll have it linked as part of like sub notes here. Wonderful read. There's the full report with lots of detail. All your medical details and great for the pediatricians and every medical person out there. For me, I like the AAP news article. Um, Again, my entrepreneurial brain just can't sometimes wrap my mind around a 5.5 year like progression, but very thorough. I mean, just with the historical context that this provides, like you said, that just the evolution of understanding, medical, surgery reports and other intervention and other medical treatments that led to this. Knowing, yeah, and what magnificent information it is. Kind of going back to what you said before, your goal is just to provide information. John, you're always kind of worried, was I giving too much hope? My stance as a parent and my stance here at Soft, we respect everyone's journey. But I think for I know the founder and for other members at Soft, we want to be respected. And the hope is through information and let us be as parents to make those decisions. And you can't do it
So
without knowing
I'm
everything.
sorry.
John, what were you going to say? Yeah.
Oh, I didn't mean to interrupt you.
No. Okay.
I think I want to just read, if I could, with Dr. Pyle's permission, the last sentence of the abstract or the summary, because when I read this sentence, it literally ran chills up my spine because it has a lot of meaning and insight to what it says. And it's pediatric and obstetrical clinicians participating in the care of these patients should maintain current knowledge of the literature to provide adequate counseling through a shared decision-making process and offer a broad range of support that is needed for families throughout the continuum of care, from prenatal to postnatal time period and extending through the child's life. So what this was really, among other points, was saying, there's no reason to treat a child, an infant with developing baby fetus with trisomy 13 and 18 any differently than any other child who has medical challenges.
Mm-hmm. Yeah. And I think when I try to summarize the paper in a very short way, I really think that they shouldn't be treated differently. You know, we take care of children, neonates all the time who have really complex, multi-systemic, life-limiting conditions. And we want to help those families kind of work through those incredibly challenging situations. And there is not any ethically, morally distinct reason that trisomy 13 and 18 should be held to a different standard. You know, they should be, you know, in that bucket of complex disease processes that we help families kind of work through whatever challenges their individual child should have. And they're loving parents who make the entire range of decisions. There are loving parents who make the choice to move forward with comfort care after the baby is delivered. There are loving parents who make the choice to offer limited amounts of medical interventions to see kind of what evolves over time. There's different terms for that, you know, trial therapy, trial of life, you know, various things, just to see, you know, where their child is going to fall on the spectrum. And there are very loving parents who make the decision to kind of go all in, as it were, and want to try every possible thing that might give their child a chance at long-term survival. And, you know, one of the comments I would also add is that part of what's so hard is that because we have limited data in this population, amongst others, you know, prognostication or guessing what a particular baby might have challenges with is nearly impossible. Like central apnea is one of these things that it seems like it should be something we can predict, you know, prenatally or postnatally, and we just can't. We just don't know. And there are lots of other things that these children are at risk for that we can't predict. And that makes it so hard for these parents who are faced with these decisions when, you know, that's one of the things I think is the next step is getting better data so that we can help families understand a little bit better what their personal situation, what the risk for their individual child might be, because we're not good at that.
It's that prediction that we can't make prenatally or even soon after birth about the respiratory
Yes.
breathing challenges that will occur. And of course, for years, especially with the paper in the 90s from Britain, it was just assumed it was central apnea. I think what we've learned, and now literature is appearing, is that upper airway issues, a collapse of the airway and birth defects of the airway probably are more common than just the occurrence of central apnea. And because that is more treatable than is central apnea, it's sort of changed the dynamic. Because that's the part we can't predict. So the recent studies that show improved survival at 6 months, a year, etc., also show that the same frequency of kids who do not make it in the first few days and weeks are pretty similar to the earlier studies. And some of that is because the self-fulfilling prophecy, a child has trisomy 18 or 13 and is withdrawn from support after a short period of time. But some of it is that there are these early problems with airways that probably aren't recognized that could be treated. So if the parents are going down that path. So anyway, thanks for bringing out that particular point.
Yeah.
Because I think what we're talking, sorry, Nick, sorry.
We'll go. If you want to finish your thought, John.
I was going to say, as Dr. Pyle, as you and I have spoken, I think as you brought out a few minutes ago eloquently about not treating trisomy 13 and 18 any differently, I do think because of what I described in the early part of the interview that came from the literature and came from the culture in perinatology and neonatology, trisomy 18 and 13 have been looked at differently than other medically complex, even life-limiting conditions. There was, I believe, and please disagree with me or clarify this if you want, I believe that there was something differently in the way they were viewed, and I felt like the paper that you led changed that idea, that if there was a bias, that isn't a reason we have to give families this information to make their choice.
I think it's a process. I think that the medical field in general is slowly more receptive to this idea. I think, one of the things we haven't necessarily touched as much on yet today is the combination of these birth differences, congenital heart defects, those types of things, with the significant neurodevelopmental impairments that all patients with trisomy 13 and 18 will have, and how that plays a role in the perception from the medical field in general, and parents as well, appropriately so, taking this into consideration when making decisions about their children. And I think there's a well-established bias within society in general and medicine in particular about disability and how that plays into what is considered a good quality of life. And I think that's really particularly challenging because it's very much a values-based judgment in many cases, and people have a whole spectrum about what they think about what is a meaningful quality of life for themselves, for their children, for their loved ones, and trying to make decisions around that should be personalized, because two people might hear the exact same information and make two very different decisions, both of which would be ethically permissible. But that again just kind of comes back to what we've talked a lot about is people deserve to have that honest and as much as possible data-based information that we could give about what it really looks like, what it really means from a medical standpoint, from a technology standpoint, and from a developmental standpoint, or to the best of our knowledge.
Thank you. I think that we talk about seeking balance.
Yes.
You just balanced what we've been talking about for the last whatever number of minutes by adding that point, because it is in such an eloquent way, because it is important to note that at this time, at least in literature, I don't know what's really happening, the majority of families prenatally and postnatally choose the path of pure comfort care and not going down the intensive intervention with or without surgery path. So I want to, both of us, you already did it, but both of us to acknowledge and support families who do actually pursue that path, because we're not advocating that every child needs the other path, the intervention, only that the parents have the information to make the decision of where they're going to go. So thank you for that balance.
Yeah, both of you, I appreciate. I mean, for me, the continual voice that I hear from SOFT membership, and this is a variety of parents that have children that are living, either into many years, or only lived a few days or a few months, or even just a few minutes. But the thing that I've kind of always heard was kind of two requests, and I think you said it well, was John, before you said it's all about the kids, and that's kind of what the parents are saying, is just like, treat my child, not the condition. So that's something we kind of have that thought, at least in the SOFT. And then the second thing is respect my decision. Respect, give hope that I can be informed and I'll make a decision what's best in that moment. There was an individual I was talking to just recently about this very topic, and the concept of longevity, the value or the return. And Dr. Pyle, you said it wonderfully. Just kind of like there's a spectrum of ethically correct and no judgment zone, if we say it kind of in today's terminology, right? Like that a parent and a family can come to the conclusion that's best for them, for that child. But if we can focus on providing information for the child and not just the condition. So like you said, we got to have to wait till birth for certain things to really see what the child has, what complex needs. Is it, grand or small within the framework of these known condition elements? So yeah, for trisomy 13 and trisomy 18 families, what I hear is just treat the child, not the condition, and then respect my decision. But I think for a lot of them, it's not necessarily. It's a variety of reasons that they're going to get to. So you brought up the word bias. If I can kind of balance bias, I'd love to have your thoughts on if there exists these bias, what's changed maybe before the AAP report, what's changed afterwards in that area. John and I, since we're SOFT members, we subscribe to the mission of SOFT, which is twofold: to support families, and the second one is to change the narrative. Well, if I could kind of like give you a real big kudos and a pat, like, champion you, Dr. Pyle, you're one of those that anybody that was part of this report, you're kind of like changing that. That's a monumental statement to put through to the world that you did via the AAP report. And so you're kind of actively changing that narrative. And so John and I have been kicking around. So what happens next? This is something for over 50 years and over 40 years of SOFT. SOFT is well into its 45th, 46th year of existence. And this was monumental. I mean, this was like the big thing. That your statement, the abstract gave chills down John's spine, right? So this is monumental. So changing the narrative is actively happening. That's what we're discussing to this point. What kind of biases exist before? What are we seeing? Where, like, let's turn the tables to what this is doing right now and where we may think this is going to take us now that we've established that there should be options and knowledge completely provided to the parents, and let them make the decisions there with their medical professionals there, for each of them. Thank you again for like just putting this out there. But again, we're looking at supporting families. The narrative is changing. Where are we going from here?
I don't know. Dr. Carey, you wanted to start this time.
Well, I think you said it again in the first line of the paper, you and your co-authors, is that the ideal model, I think, in changing practice would be to implement and institute a shared decision-making process, whether it's prenatal early on at time of diagnosis, might be 18, 19 weeks of gestation, whether it's in the NICU, a few days. And we know that shared decision-making is maybe become sort of this ideal, but I think it's an ideal that we should strive for. And that in the future, in teaching communication skills to those that come with us and after us, that becomes the change in practice. So that, again, it goes back to everything you said, Dr. Pyle, which is information. And I wrote it down. Where did I put it? Good ethics. No, good data. Which way did it go? Good data equals
good ethics begins with good data.
Right. Very good. Okay. I wrote it down. So there we go. So now data's evolving. It's increasing. There are more studies going on as I talk to people around the country. The Trisomy Collaborative, recently created 2 years ago, with Marks on their executive committee. There'll be opportunities for more studies that'll be facilitated by the Trisomy Collaborative. Again, on all leading for better information for families, better training for our now colleagues and ongoing colleagues to institute, I think, what are the principles that you laid out in the abstract of the paper.
Yeah, and just to jump off of that point, shared decision making, I agree, is this sort of catch-all term that we use now and do strive for. That is the expectation in modern medicine, particularly in Western medicine, that it's shared decision making. But what that actually means in practice is quite variable, and um, I've been doing this, 10 years probably at this point, and I think every single time I meet with a family, I'm still trying to find better ways to communicate the information, to ask questions in the right way so that I'm understanding their values and, meeting their needs in terms of the information that they would like to have. Some people want statistics and some people want big picture and some people want every little detail, and there's such nuance there, and different worries that different families have, and this whole thing is such a complex process. And I don't know, that we still know the best way to teach those skills to our trainees. I work with residents and fellows now, and there's ever evolving attempts at improving the education and helping people learn these skills, because it is really hard to have an hour or 2 hour long meeting with the family, convey to them all the information that they need about a diagnosis they've probably never heard of, and then somehow help them make decisions about what they want to do for their child. It's a huge ask, and this is why we also talk about doing, multiple meetings and sequential meetings, and talking with different subspecialists and ensuring that, the family is able to have their questions answered and have a support person to try to help improve that shared decision making process, because there's so many barriers in the way from both sides. The medical team has other patients that they're trying to take care of and other things they're trying to do, and the families have other kids they need to pick up from daycare and a job that they're taking a day off from, and there's all these different things that make it hard to do really good shared decision making in this space particularly. And to go back a little bit to what Nick had mentioned about bias and how that affects this as well, because everyone is a human being that's involved in this conversation, and we all have biases. And I think knowing what your own biases are before you go into the conversation and being honest with yourself about what those are, like, you can't make them go away. Like, we all have feelings and think, I would do this or I would do that. And that's okay. But seeing it, acknowledging it, and then setting it aside so you can go into these conversations and really help families through these decision processes, I think is the key. And we've seen an evolution in society about disability in particular. Again, John, I'm sure you could speak to this. 50, 60 years ago, patients with trisomy 21 or Down syndrome were also allowed to potentially not get medical interventions and died in our NICUs without getting treatment, because it was felt at that time that the disability was so significant that these children had no chance at a quality of life that was reasonable. And nowadays, no one would consider that acceptable. And that just goes to show that not just medical knowledge evolves over time as we get better data, but understanding about disability and what that means and how we can support these children is also evolving for time. And again, that just sort of makes these decisions harder. It was easy 70 years ago because there was no decision to be made. And now it's so much harder because there are choices involved, and we have options. We have support systems. We have medical tools that we didn't have. So, it's harder for everyone nowadays.
One of my mentors in bioethics, so you probably know Dr. Jeff Bodkin, who was on
Mhm.
faculty here at University of Utah. Now is like me, retired but still working. And Jeff's been a part of the AAP's bioethics decades ago. he said, and I know it's only when you have these choices that the ethical dilemmas arise. I'm not saying it exactly the way he would have done. Is we have the choices, and so I think you pointed out quite astutely that our challenges in being able to convey in a short period of time what the challenges are for a family, and I think you characterized it nicely in talking about the disability part and how that enters, and the other, which we've talked about all morning, is the medical complexity, is having a family be in the position to understand what that path means, and to do that realistically. I've struggled with that over the years, as we even have used medical complexity more as a descriptive term. But what I came to and I'd be interested to see what you would think, Dr. Pyle, in our own fetal center, and all along, even counseling families, especially in the NICU, I always felt it was important for me to add something about the joy and positive aspects that I've seen in the families I've known in Utah and at soft conferences. Yet I knew how to script that, how to actually say that, and say it, and truthfully and genuinely, to balance what is all of those challenges. It is to me still a challenge. And I've had parents say in the fetal care center 2 times I can remember vividly, where one of the parents would say, "You've actually made my decision more difficult." By saying that, and you can see why. And so maybe there are other words that we can bring in, because some of this is hard to actually put into words. But anyway, I'm so glad you brought up what we might call the disability part, and you're totally right about history and Down syndrome. When I was a pediatric resident in the early and mid 1970s, and a fellow in the late 70s, our surgeons still offered to families of children with Down syndrome who had a blocked esophagus for whatever reason, duodenal atresia, tracheoesophageal fistula, the option of no surgery, which meant that basically the child would only have IV fluids as far as hydration. I won't say anything more about what that would mean, because it's clear. But I did see that particular event. I'm talking about it now. Maybe it had some influence on me, but anyway.
Yeah.
Yeah,
I mean, I
I
think,
struggle.
go ahead.
No, I was just going to echo what John was saying about finding the right words for the families is an ongoing challenge, and different families, I think, respond to different words, and so there's no one size fits all there.
Yeah. I mean, the shared decision-making statement, although, like you said, Dr. Powell, very encompassing, like there's a lot going on with those couple words, but what a goal what that is. I mean, what was the quote again? We got to say it again, because I think it's so good. Good ethics starts with good data, or lots of data. What
Yep.
was it exactly?
It's short and sweet. Good ethics begins with good data.
There we
And I
have
can't
it.
take
Good
credit for
data.
that one. I got that from my mentor, Dr. Mercurio.
I'm going to steal it, and I'll give credit where credit's due to the both of you. But yeah, to me, I think that's what we're striving for, and it's one of those things, I think, in life where we look at it and says, "Man, I wish." The only way that we get more data is through data, and data comes about through time and through information gathering. So, like, one of the key aspects that software all about. This is probably John's favorite part of trying to find research studies. We have our surgical database that we've informally collected over the years by the volunteers of the parents submitting information, and we've used those growth charts. John and I were just talking about in the book that we're helping put together. We have growth charts listed on the website. I mean, there's just, and so I think for a lot of families, especially ones with children that have passed on, to be a part of the journey for the next wave of parents, for the next parent, for the next diagnosis, for the next child, being involved in that data is important to them. I think that's at least the context I've always felt. John, you doing the interviewing and you being, boots on the ground with some of these reports. I think there's a lot of families, a lot of parents that are just want to contribute. And that's one way to do it, is just to add to that good data. Because then, more informed decision-making, more informed shared decision-making can take place. There's a lot, there's just so many other things that I want to cover, and we got some time left. Let's dig a little bit into this, in the AAP report. Is there anything you want to, anything specific that just is on your radar, either one of you, about this report? John, you already talked about the abstract. Was there anything else that we cannot miss, at least in this interview? This might become a multi-part thing. Dr. Pyle, I know you're busy as
I
ever.
wanted to ask Dr. Pyle,
what's kind of in there that we got to talk about?
Well, in one section of the paper, you identify the subheading is actually moral distress. And there's only one paragraph because we know so little, but I didn't know, just as you, as a physician, but also in the neonatal setting, have you seen that? Could those words be applied to what some of your colleagues, whether at other places or at Connecticut Children's, where you actually see, even in this setting, moral distress?
Yeah. The short answer is yes. I think anytime we have a particularly complicated patient in the NICU who is having multiple organ systems involved, usually they have a breathing tube, they're on a ventilator, and they have this known high risk of death early on. I think that can lead to moral distress for the staff. There's a lot of questions about, are we doing the right thing here? Are we just doing things to the baby instead of for the baby? And I think some of that can get clouded at times because the babies who tend to stay in the NICU a longer time are those that have more complexity. They have more respiratory issues and neurologic issues, cardiac issues, and we are not necessarily seeing those children with trisomy 13, 18 or other conditions who have less complexity, less birth defects, who then are going home. We don't keep them in our NICU because they're doing okay and they go home and we don't see them. And that's sort of a known bias in both the pediatric ICU, the neonatal ICU, adult ICUs. This is a known phenomenon that we remember, and we see the hardest cases, and they really deeply affect our bedside staff, particularly who are, our nursing teams who are at the bedside every hour of every day with these children and really worry about potential suffering that the baby is experiencing or the child is experiencing. And, I coming back to a point that you made earlier a couple of different times, John, that what's really changed your perspective is seeing these patients and seeing these families in the outpatient setting, which as a critical care, team, we don't see them in that way. We don't see them when they're well. We don't go with them when they're at the playground with their sibling, and doing okay. And, maybe they have a G tube and a cannula and that's, what their parents have chosen for them, but we don't see them well for the most part. And that adds to the distress that people experience when, we also see those children who do die in the short period. And that's our frame of reference. And that can be really hard on staff. And I think doing a better job as a medical field, perhaps, than as education sort of takes this into their curriculum a little bit better, trying to highlight the experience of families at home with children with medical complexity. This is something that, I think we as a field aren't necessarily good at all the time, is helping people see that longer term sort of well child in their home environment where they're smiling and enjoying their, family dinners and reading books together and doing those sort of experiences that are incredibly valuable and meaningful for the family, for the child. We don't get any of that. And I think that really contributes to the challenge of caring for the sickest of the sick in the ICU.
Yes, and again, I appreciate you providing balance again, because that frame of reference that you just portrayed also applies back to the obstetricians, which
Yes.
which we also sometimes, maybe myself and others, overly criticize for the use of lethal and incompatible with life. But for the average obstetrician, or even more maternal fetal medicine, an amniocentesis reveals trisomy 18 or 13. At that point in time, as a result of the amnio, more than half of those infants will not survive pregnancy. They won't come to term. They'll pass away in utero. And then they know that the obstetrician, that many of their patients' children now in the NICU don't survive the first few days for whatever reason. So in some ways, you can see the lens of the OB, and you just increase my lens too of what you have in that situation. That probably not just the articles I referred to recently, but probably those experiences, and I hadn't characterized them as moral distress, but I think that's a good label, leads to what I might oversimplify as a bias, toward never intervening. And you can see where that bias arises.
Absolutely. And to take sort of a related but sort of sidetrack from, coming back to Nick's question about what else I would mention from the paper, is that I think it is so critical to have an established plan, a guideline from an institutional standpoint. That was actually that first paper that Mark and I wrote back in 2018, I think it was, along with Ellen Fleischman and George Hardart. And that came out of our process for wanting to have a definitive guideline for our staff at Yale, where I was a fellow, because beforehand, as I had said, we did not offer. And then we went through this whole process that we kind of described in that paper, and came down on the side of, we treat these kids like every other, complex medical condition. There's no separate exclusion of children with trisomy 13 and 18 as there was previously. And I think it is so important for every institution that takes care of infants and children with trisomy 13 and 18 to have an established, clear guideline, because there are still, families who go to centers that are hearing different things depending on who they talk to. And that, to me, is troubling at best. And that is something that I would want to emphasize from our paper, is that groups need to have these discussions. And if they feel that they can't offer interventions for these children, that's a choice you can make as a provider. We don't want to force people to do things that they think they can't do for whatever reason. But then they are obligated to refer those patients to an institution that is willing to discuss those interventions. And some of it's because they're just not set up to, do that kind of care. There's lots of hospitals in my network that just really can't provide those types of interventions. They're not, a level 4 NICU that can, intubate and maintain a baby long term on a ventilator. And so they should never be offering that in their institution. But I think the key is to have those conversations and to be clear, so that when you have a patient come through your system, you have an answer that everyone on your team has agreed to support. Even if they may have some personal feelings about it, they have agreed that we are coming across with the same message from everybody.
Yes, very good. And in fact, what I liked about your paper when I read it, the one in Journal of Perinatology, that not the AAP report, was that you did provide some written guidance for that institution as to make that happen. I thought that was a really unique aspect to the 2018 paper. For people, and I think you clarified it nicely about some institutions are not in that position. It's not like they hold bias against non-intervening. It's that by intervening, it's that they're not. They don't have with the other specialists they need to carry out that care.
Yeah, Dan, like a couple of things. You said some just wonderful things that I just paused and I muted myself so I didn't yell into the microphone. But just your declaration that institutions should make these guides, I think to piggyback on what John you were just saying, as far as other conditions, it would be the same thing, right? We don't have this machine, or we don't have this individual that has this, there's 10 people in the world that can do this surgery and we don't have one of them. That's just the way it goes. Or, close friends with someone in small town Arizona, they are the hospital director and they're not set up like Phoenix Children's Hospital. And that's just the way it is. So I think just clarity around who we are, what we have to offer, but we are ready to provide a synchronous message across the staff. One cool thing that I think it came about your article or your report is a member of SOFT reached out to us. John, you were in the meeting when they were talking about this, but we have a member, Gina, out in Florida, just at a hospital. Sorry, Gina, I don't know your hospital's name by name to give them a shout out, but she said the hospital she's a nurse at, they know she had a child with trisomy 13, so now she's on the committee to help make one of these guides and one of these standards that they're gonna follow. So it's already happening. So Dr. Pyle, thank you. I might take that sound bite of you just saying, every institution should have this. We put that in the report. I've said it in 2018. Now I said in 2025. I think it's time to do it if you haven't done it already. What a magical, that will change a lot. If I can also just circle back to moral distress, I'm an average person. To think of these wonderfully, they give their life. You medical professionals across the board, you've volunteered, or I mean, you've chosen a profession of giving. And then I never had that perspective that, they're in the hospital. They see people in the hospital. And so not see them on the playground or to see them in their house. I think of myself as a 4-year-old, seeing my sister. I was playing with her in her, custom made crib in, 1986. So my perspective is definitely different than her pediatrician who never climbed in the crib with her. So just a perspective change for me, a paradigm shift of just thinking, how do we do that? John, maybe, Barb and Josh Bradley on the board would kill me for saying this, but maybe we just need to fly out all the I'm just kidding. All the doctors at the next conference. And just get everybody to hang out at the family reunion, we call it at SOFT. But what perspective and understanding that there's challenges within the giving that doctors and medical professionals give that are there on the front lines. And we love that they're on the front lines, but it puts just a different perspective as to what they see versus maybe what is a possibility. So just a fantastic kind of overarching, you changed my perspective on that. So sorry to hit that so hard, but man, what a not a creative, but what a wonderful just description of what you're seeing as part of your life and what others that do what you do right there in the hospitals, the moral distress of that.
So
that
Nick,
is very
could
cool.
I add something there?
Yeah, please.
Nick Holladay, the co-founder of SOFT with Pam Watson, also mother of Rachel with trisomy 18, shows a video with sound and music of, and I don't know what the number is, I'm going to guess 100 children, maybe more, a little less, mostly with trisomy 18 and 13, sometimes also other trisomies like trisomy 9 mosaicism, in Halloween costumes, in front of Christmas trees. They might be babies who are actually quite ill at the time, who have an obvious tracheostomy and oxygen as well, but in the normal family situation with their family picture. So Chris has created this video. I have the last 4 of them right up here, one of these kinds of flash drives. Prior to that, they were DVDs or CDs, whatever. When John Edwards saw, maybe it was the first one Chris did, I'm not sure, but that was 1990. When John Edwards saw it, he said, everyone needs to see that. And of course, it was primitive audiovisual at the time. Hal would have to say what we did for that particular one. But John Edwards left saying, I've never seen anything like that. And so in one way, it is balanced, Dr. Pyle, because it's even the kids who are very sick, even the kids who are in NICUs, but it also has Halloween costumes and all the rest of regular life in different ethnic backgrounds, different parts of the world, different ages, of course, different genders. I'm surprised we haven't given Chris some sort of award for that every year. Maybe she should receive the Carey Dean Holladay Award one year.
Maybe. I think there's somebody at Soft that has been bugging me to do that. And I was like, I don't know if you can give your own award to. Anyway, but I just think the perspective is there. We see it, and so there's this bias both directions. If I can say this on the record, as someone that's been around Soft, someone that respects and loves, I've been talking with a lot of other organizations that do wonderful levels of support for families. We're not alone. So by any means, if you're listening to this, if you're one of those other organizations, we love you. We love to figure out how we all can help each other. But one thing that I do know is because of these pictures, these videos that we make on a regular basis, you go to our website and you see kids of all ages, ethnic backgrounds, spanning the globe. I'll quote you, John. There's sometimes that perspective of, that's what we want. We want kids to live a long time. And every time I talk to a parent, they just want to be heard, respected, and to know that their child had meaning and value, whether it was minutes, whether it was in utero that they passed away. Like any of those scenarios was valued and respected. If I could add just, neither of you know this because I've been talking to this family. His name was RJ. He lived just a few minutes with trisomy 18. I've been chatting with the mom, and RJ would have turned 10 in September. So 10 years ago, RJ was born, only lived a short while. But they decided as a family, this mom, this dad, and extended family did a celebration and combined it into a fundraiser. And what joy you just saw. And it probably was 100 people. They had fireworks. I got pictures and videos from her. I'm writing a little blog thing, bragging about how much fun they had. But what a cool experience. And that's not alone. Like that was just because it's on my mind because I was just texting with her these last few days. But this happens regularly. Families have these wonderful experiences a lot, many, many years or few moments. And let me just add, not to talk too much about myself, but as a sibling of a child, I actually have 2 sisters that have disabilities of, differing kind. But Carey with trisomy 18 is still someone that is my sibling and changed how I perceive things, even though I was only young when she passed away. So just, it's a variety of things, and that's what we're hopeful for. So Dr. Pyle, I think every time you've talked about, this shared decision making, I think that really ultimately comes down to, what do the families see? What do they need? What does that child deserve, need at that moment? And it's going to be fluid. Um, just like, some kids live past the weekend, like Carey and others live, into multiple years. They get teenagers. Those decisions change like constantly. So how do we have the most information to provide the best decision for that child, for that parent? What a wonderful goal that would be, is just to be, at that point. We could go on for days. I think you two are just amazing people. And let's just kind of wrap up. What are some loose ends? Let's tie some things together. We've had some great sound bites. This is a great story arc that we've created here. But what are some things that we just need to make sure are clear to our listeners?
I think this theme of balance,
Mhm.
it's just like shared decision making. Balance should be part of shared decision making. Easier said than done. Um, m- continued conversations, continued thinking about that.
Yeah, I agree, John. I think we've covered a lot of ground. I mean, there's always more to talk about in this space, and how it fits in with broader neonatology and medicine and society in general. And there's so many different pieces that are all sort of highlighted by this patient population. And I agree. I think trusting families to be able to make decisions, and trusting ourselves to be able to convey that information effectively and to help them in their decision making process. And not just sort of handing over the information and then having them walk away from you. Like, this is a shared process. I think, not to just keep saying the same words over and over again, but it's not the parent making the decision, it's not the physician making the decision. It is a group effort at bringing together all those pieces that we've been talking about, and helping each other through that process.
I love that. And I just wanted to let that breathe, because I think that was like just clear as day as to what the end goal would be. If I could add, maybe there's like, I think in diagrams. So there's this like decision making loop of, we provide, as a medical professional, here's some reports that are out there. And then the parent kind of noodles on it and talks on it. And then there's more, and it just kind of is this circular thing. And hopefully it's expanding, right? Larger and larger. So there's a more robust opportunity for decision. And yes, that will make it harder. John, you mentioned earlier that, man, your information you just shared with me now makes my decision harder. And so I know that's not our end goal. Our end goal would be that, I think in today's vernacular, there's always the live with no regrets kind of desire. And it's just like, come to the conclusion and come to what's right for this child, and do it together. But I think one like interjection of data, all this new data, all these new reports. John, you talked about the Trisomy Collaborative, and there's an increased number of that I'm just seeing. I'm on the ground level, but I'm feeling like there's new reports and new medical studies, and the next wave of medical students are asking questions that lead to new maybe reports here coming up. But it feels like there's just like this injection of, this is what we're hearing, this is what we're learning, these are the studies that are being proven. And so that just adds to that decision making sphere of just growing and growing and growing. Again, hopeful that
No, there's
families,
no question, Nick, that
go ahead.
there's no question. There's much more discourse, discussion, energy going on, not only here, but especially in the U.S., but I was on a South African video call a few months ago talking about care in South Africa, and it was Dr. Pyle's report and the American Association of Thoracic Surgery report that led them to be relooking the South African Medical Society about care. So there is definitely an energy level, an interest level, a community level that we haven't witnessed before. And again, it's a lot of it is the data. A lot of it is changing culture and times. But it is also, again, the data.
Yeah. I think as that, again, the willingness of families from the past, from the present, contribute, we talk. I think that's the biggest thing, is just this dialogue has to keep going as far as what is happening, what is happening in the hospitals, what is happening at home, what are the things that are happening for a variety of children at all their different ages and backgrounds. And let's just keep moving this ball forward to provide more and more information. That's good data, so good ethics can come about. But I don't want to have the last word, because this has been so monumental. Dr. Pyle, if I could I don't know if you have been able to follow the excitement. I'll give it from the soft perspective. John, maybe you can compliment Dr. Pyle a little bit from your perspective. But I know when I sent out a press release amongst the soft members and tried to do other elements to push this narrative changing document that you were author of, man, the response was just overwhelming. I should have started with this, so you would have just been, so filled with this. But there were lots and lots of responses from parents that were just so excited that they're being heard. Just the volume of people that were so grateful for your willingness to go on record, to use the platform of the AAP, to have this declaration of what many families over the decades have felt, which is treat each child as a child, not as a condition. Just it was overwhelming. If I could just build you up for the rest of the day, for the rest of the year, for the rest of your career, what a monumental moment for so many parents and so many families that you were able to get that report done. So I just have to say from them, I couldn't give you the biggest hug or digital thank you. So whenever we run into each other, just know that's what's coming your way. But from the soft members, I can speak on their behalf, because I was told, thank you for all your efforts. We appreciate you and grateful that you were able to see that report through. John, I'll let you say something, and then Dr. Pyle, maybe you can end with whatever's on your mind, and then we'll wrap up.
I think we did capture, I'd have to relook at our interview. I think we captured so many of the major themes in this discussion. So I thank you, Nick, for generating what I would consider to be a great conversation.
Thank you. To Nick and to John, I really, really enjoyed this conversation. I have been thinking and writing about infants and children with trisomy 13 and 18 for years now, and it feels really good to have it out there, because I think this is something that's been missing for myself and my colleagues, to have clarity around this, very challenging situation, so that people aren't having to continue to question, what the right thing is to do here, and to have the AAP really come through on this issue and answer to those questions from our field, I think is also tremendous. And it was a huge endeavor. Lots of people were involved, and I'm incredibly grateful to everyone along the way who really has contributed to this work and continues to contribute to this work. I agree there's a huge number of people that are actively working to build out data for these children and their families. And I just want to, again, thank everyone who helped along the way and has really taught me so much along the way as well.
Again, Dr. Pyle, thank you so much. Thanks for taking time. You are a busy person, doing a lot of good there in Connecticut, doing throughout the world, just putting that declaration out there. If I can add, so here's what we're going to do, everyone. We're going to close up. Thank you, John. Dr. Dr. Carey, you are just, I got to give you the official title. Dr. Carey, you are so wonderful. Thank you for connecting with me, the both of you. You guys are just remarkable. Dr. Carey is retired, but he's not retired because I keep bothering him. So I think I'm your problem, John, here on this. And Dr. Pyle, don't get too close to me or I'll keep asking you questions. Maybe we'll circle back in a little while to see what the results have been with the AAP report. But I already get the feeling that some of your requests of institutions making guides and standards of care and what they're going to do is already in the works because I've heard them. And so thank you to those institutions that are already following that. If you're not doing it, now's the time. There's great information in those reports to get that done. So thanks so much, everybody. Again, we're talking trisomy here, and it's just a wonderful time moving forward with everything. Again, thank you, John. Thank you, Dr. Pyle. And we'll cut it here.